In any system, the behavior of each component has an effect on the performance of the whole. When we optimize individual components, we degrade the system's performance overall. We benefit from high reliability systems every day. For example, when we turn on the tap, we don't think about the system powering water to our homes. It's just always there. Or consider the intricate system that delivers fresh cut flowers to your local market, even in winter. How does that happen? How about the internet? Somehow the internet lives in your pocket. These are the results of systems, operating quiet and unseen, backstage to our lives, ever present, patiently standing by to provide. When we become aware of the system behind the results, it's likely because we're experiencing a delay in the service. We take these systems for granted precisely because they are reliable. The higher the reliability, the lower our tolerance for interruptions. And though we may be frustrated by the inconvenience, we probably don't understand why the system has slowed. Frustration rarely leads to comprehension. Think about the interstate freeway system. The promise of uninterrupted, motorized travel is right there in the name. A lightly traveled stretch of highway, say 20% utilized, is every motorist's preference. Now the system can maintain full speed at 50, 70, 80% utilization. But at these speeds, everyone's undivided attention is vital. But when utilization goes up from there, the freeway becomes far less free. Everyone has to slow down. Most of us have been stuck in traffic, but few of us understand traffic science. We just get mad. We fail to understand that we're not in traffic, we are traffic. The freeway system is designed to accommodate our vehicles and millions of others, all at once. But it does have a maximum capacity. The closer to maximum, the slower the traffic moves. A fully utilized freeway is gridlock. Sticking with traffic for a minute, consider air traffic control, a system with extremely high reliability, despite passenger frustrations. As you approach Salt Lake International, the air traffic control tower rises above the building, so the specialists inside have unencumbered, holistic visibility of the airport grounds and the skies. Those experts maintain situational awareness of and for every aircraft within a 50-mile radius. They monitor altitude, speed, and direction of all arriving and departing aircraft in the current moment and hours into the future. A master's grasp of this dynamic environment is required to expedite the flow of aircraft and to synthesize several data streams into real-time information for flight crews. The air control specialists don't just provide information, they also give direction and authority to flight crews as to when and where they can move their planes. The smooth and safe flow of aircraft depends on adherence to this structured authority. The air traffic control system hums along, away from all the action, enabling your flight and ground crews to get your plane in the air. Meanwhile, flight crews, ground crews, and gate staff have a limited view. This is by design. Airport operations require their expertise be focused on one flight at a time. As a passenger, you want all that collective attention on you, your aircraft, and your flight experience. Of course, at crowded airports, we often wait. And while our individual experiences can be suboptimal, on the whole, the system is running optimally given the current situation. As the airport approaches maximum capacity utilization, optimal can be pretty frustrating. But it would be even worse if any single gate or airline were to be prioritized over the others. It'd be great for that one small subset of travelers, but overall, everyone else in the system would suffer. University Hospital has a patient traffic control system, the Patient Placement Center, also known as Bedboard. The hospital welcomes an average of 87 new patients into its 505 inpatient rooms every weekday. Between 7 a.m. and 7 p.m., a patient admits or discharges every 4.5 minutes. Average weekday utilization often reaches 98%, and it's up to the patient placement specialists to prevent gridlock. They constantly synthesize several data streams into real-time information for our care teams. Working within a 2% capacity margin requires an unencumbered, holistic view from the digitized control tower. They maintain a 6-hour situation window of boarding, admitting, and discharging patients. Bedside teams have limited visibility. Their attention is concentrated on their patients. Similar to air traffic controllers, bedboard specialists are vested with the authority to determine placement for our patients because they alone have the holistic view. For the system to work, the players with limited visibility must honor that authority, even when some patients are placed in suboptimal environments. In the hospital, attempting to prioritize every individual patient will degrade the overall system. Occasionally, a frustrated physician will appeal directly to the Chief Medical Officer. That is, CMO, the hospital's top doc. The CMO will very likely ask, what did the Patient Placement Center say? And the CMO will then reaffirm the center's authority and decision because the best possible outcome for all patients depends on adherence to this structured authority, especially in a gridlocked system. Here's a typical morning. At 9 a.m., a cardiothoracic surgeon, currently in the OR with patient Albert, wants Albert to go to the cardiovascular ICU, which is currently full. When it's full, the surgical ICU is the second best option. Today there's one bed available in the surgical ICU, but it's next to a patient with active COVID, and patient Albert is immunocompromised, eliminating that option. Meanwhile, patient Collins is at the top of the transfer center wait list. Dr. Young has accepted Collins as a patient, but there's no bed available. Then, the South Jordan ER calls about patient Gutierrez, who's receiving emergency treatment for a stroke. Patient Gutierrez is already our patient because he's in one of our emergency rooms, so he has rights to come to the main ER. His ambulance will arrive here in 90 minutes, despite there being no free beds in the neuro ICU. From elsewhere in the system, Dr. Pollock informs the Patient Placement Center that her patient, Mrs. Liston, is going to the OR today instead of Mr. Mallory. Now, Dr. Pollock and her PA, Sherry, work together every day, but rarely side by side. That's important because only 10 minutes ago, Sherry told the Placement Center the exact opposite. Both Dr. Pollock and her assistant, Sherry, were in possession of correct information at certain points in time, but information in dynamic systems has a limited shelf life. No one ever says, and not everyone even knows, that all information comes with the unstated caveat, my best info at this moment. It's now 9:15. Remember patient Albert, the one trying to reserve a spot in the cardiovascular ICU? The Patient Placement Center's screens show 8 tiny sedan icons associated with the acute cardiovascular unit, called the CVMU. These icons mean they anticipate 8 patients to discharge today. These discharges will make room for patients who no longer need intensive care. That is, they don't need to be in the CV ICU, but they're stuck there because none of those 8 has left yet. To sort this out, the Placement Center opens a dialogue with the CV ICU and the CVMU charge nurses. Good news just came in. Patient Reynolds, a transfer who came in 2 days ago, just went to surgery and gave up her room. Now, the Placement Center can release a boarder from the emergency room. Of course, Reynolds will need a new room after her operation, but that's a problem for later. The good news is cut off because the Placement Center is suddenly taking flack from Dr. Young about patient Collins, who's destined for an acute medicine unit. Back to Gutierrez, the emergency stroke patient. Looking an hour into the future, the placement team thinks room 3 in the neuro ICU may be available by the time Gutierrez arrives. Never mind. Things just changed because patient Lincoln, a critical neurosurgery case, just left the OR 2 hours early and is now boarding in the PACU. Gutierrez will have to go to the main ER to board, and Lincoln will get the first available bed in the neuro ICU because the ER is better equipped to manage a stroke patient than the PACU is equipped to manage a neurosurgery patient. Whew! And now it's 9:30. The hospital is on red critical census, and though many players are frustrated, the system is performing optimally thanks to Patient Placement's holistic visibility and central authority.